Hi everyone, my name is Megan Pollier. I'm the Clinic Partnership Manager here at MAVEN Project, and thank you all for joining us today and our friends at El Rio Health FNP program in Arizona for hosting today's session titled Dementia, Evaluation and Treatment with Dr. Richard Mesher. Dr. Mesher retired from a general neurology practice after 37 years in practice. For 9 of those years, he was Chief of Neurology and Neurosurgery. Dr. Mesher engaged in clinical research, including participation in drug trials for multiple sclerosis. He also had a subspecialty practice in movement disorders, actively participating in a program for deep brain stimulation in Parkinson's disease and other disorders. 6 years leading up to his retirement, Dr. Mesher practiced general neurology at Virginia Mason Medical Center in Seattle, Washington, where he taught internal medicine residents and medical students. And he has been a member of the American Academy of Neurology since 1983. And with that, I will hand it over to Dr. Mesher to present.
Okay, excuse me. Thank you, Megan. I appreciate the introduction. Thank you for allowing me to speak to you today. I would encourage questions, uh, uh, and I guess there'll be time at the end, so I hope that's not too burdensome to write your questions down. We are going to talk today about the evaluation and treatment options for dementia. The talk is really going to focus a lot on Alzheimer's disease, and I'm going to talk about the workup of dementia and the diagnosis of Alzheimer's disease. And then there are a lot of new developments in the field of Alzheimer's disease, both in terms of diagnostics and therapeutics. And the last portion of the talk is going to deal with some medications that are now available to actually treat Alzheimer's disease. And I'll review those and the pros and cons. And again, I hope you have some questions at the end. So I have no disclosures to make. And you already know about the CME that you can get for this talk. The objectives are to diagnose dementia, including clinical diagnosis and testing. And then we're going to talk about how to evaluate and treat Alzheimer's disease, both symptomatically and with some of the newer disease-modifying medications, as they're called. And this will include the newest addition, which is directed towards this protein that's deposited in the brain called amyloid. So just to have a general discussion, cognitive domains include things like executive function, which is reasoning, multitasking, uh, and so forth. This is localized in the frontal areas mainly. Memory, of course, is an important one, both long-term and short-term memory. Short-term memory, new memories are formed in the temporal lobes, particularly the medial aspects of the temporal lobes, and we'll talk about why that's important. Language is a cognitive domain. It's in the left hemisphere in right-handed people and in half of left-handed people. And then there's visual spatial function, which is located more posteriorly in the occipital and parietal lobes. So as I mentioned, the inside of the temporal lobe, where that retractor is where the hippocampus lives. And this is an area of the brain that helps form new memories, the so-called short-term memory function. And this is the area that's very important to be aware of in terms of people presenting with early dementia. So what is dementia exactly? Well, it's a generic term. It's kind of like pneumonia can be caused by many things, many organisms. Dementia has many causes. It's an impairment in intellectual function affecting more than one cognitive domain. So what that means is if you just have a poor short-term memory function, but other cognitive domains are intact, you're not yet meeting the criteria for a diagnosis of dementia. In order for it to be dementia, it has to, your intellectual function has to have more than one cognitive domain involved, for instance, language or frontal executive function. And then this interferes with your ability to work or function socially. It does represent a decline. It's not a static process. It's a progressive problem. And you have to rule out delirium or a major psychiatric disease. So you have to rule out medical illnesses, which we'll talk about in a minute. What's mild cognitive impairment? You may have heard this term, MCI. Well, it's an abnormal decline in cognitive function, but the patient can still function pretty well. The most common type involves the presentation of short-term memory trouble. This is called amnestic mild cognitive impairment. These people already have Alzheimer's disease. It's just at an early stage. And every year, 15% chance of converting to dementia, meaning other cognitive domains become involved, is the risk of this. So people who present with new onset short-term memory trouble, which is progressively worse, they're at high risk and eventually will develop Alzheimer's disease. It basically is early Alzheimer's disease. I would think of it that way. So there's other causes of dementia, of course. These are the main causes. Alzheimer's disease is by far and away the most common cause, but vascular dementia due to multiple strokes and actually mixed dementia with vascular involvement and Alzheimer's is 3/4 of the patients. There are other ones, Lewy body dementia, which involves looking like you have Parkinson's disease, frontotemporal dementia, which involves the frontal lobes and a very different type of pathology. I'm not going to go into these today, but just so you know that they exist. So Alzheimer's disease, it's the most common neurodegenerative and dementing illness, as you probably know. The prevalence doubles every 5 years after age 65. So the older you get, the higher the chances are that you're going to come down with Alzheimer's disease. And after age 90, the prevalence is 50%. So it really is a age-related process. The risk factors, I just mentioned age. Mild cognitive impairment, I just mentioned, is a huge risk factor. And then there's this ApoE allele, which codes for a lipoprotein. And there's a certain pattern in it that if you have this ApoE4 allele, particularly homozygote form, your risk is quite a bit elevated for eventually developing Alzheimer's at some point in your life. It may not be till you're 90, but your risk is higher. Your risk goes up if you have a first-degree relative who had Alzheimer's disease, especially young onset, i.e. below age 65. And your risk goes up with vascular problems, diabetes, heart disease, etc. We'll circle back on that in a minute. Now, in terms of Mendelian genes causing Alzheimer's, there are early onset syndromes. They're very uncommon, but there are specific genes, which I won't go into. They should be looked at in young onset patients, for instance, someone who develops Alzheimer's in their 40s or 50s. So this is just some pictures of the brain. And again, direct your attention, lower left is the medial temporal lobe there, the hippocampus. It's where the pathology starts. Eventually, the pathology spreads, the brain grossly atrophies. There's gross atrophy of the temporal lobe structures and also of the cortex. the ventricles enlarge, brain looks shrunken. Um, Atrophy on a scan is nonspecific. So there are people who do not have dementia who have some or even significant brain atrophy. So that finding, if you get it on your, you get a report and it says there's moderate cerebral atrophy, it's a nonspecific finding. But definitely the atrophy correlates with the progression of the disease. So how do these people present? How do they come to clinic? Well, most commonly a spouse, care, a close friend will bring the patient to clinic and report this short-term memory trouble. Patients sometimes are aware of it. A lot of times they minimize it and they lack some insight into the problem. So it is really important to get a history from someone who knows the patient. So as I've mentioned already, there's loss of short-term memory. There's often some loss of orientation, particularly when the patient goes on a trip, gets a little confused where they are. There should be a smooth, gradual decline without dramatic fluctuations. And then again, over time, other domains become involved and the diagnosis of dementia is made. The patient converts from this mild cognitive impairment diagnosis to dementia. These patients are prone to depression and very prone to anxiety. They can become irritable, hostile, or they can become apathetic. They have delusions, often about people interfering with their financial uh, uh, issues, and they can have hallucinations as well. There are sleep-wake changes. We often hear about this sundowning. A patient, often in the hospital setting, becomes very confused at night, and there can be agitation. All of these problems present difficulties for caregivers and families, and really need to be addressed. So how do we do this? Well, again, you ask a close informant. What's happened? Is this memory problem been there for a year or two? Is it gradually getting worse? You want to know if they have any other neurologic symptoms, of course. Um, and it helps to ask things like, well, does the patient repeat themselves? Do they ask you the same question? Do they lose their keys? Do they have trouble working the remote on the TV? Has there been a change in the personality? Are they having trouble speaking? And you want to know if they can't do things that they used to do, hobbies, manage their checkbook. Is driving a problem? Driving's a big issue. Have there been fender benders? So it is really important to take a good history when you're dealing with this kind of problem. You want to know what their general medical problems are. Have they had strokes? Have they had head trauma? Did they have meningitis or encephalitis? Is there family history? Uh, Obviously, you want to know about alcohol abuse and drug usage. And what we're really trying to get to are some things that we can either reverse or modify uh, and help the patient, even if they have Alzheimer's disease. Some of these things can, drug use, alcohol overuse, certain medications can make things worse. I apologize for this busy slide. Basically, when someone comes in with cognitive decline, you want to look for metabolic problems. You want to make sure that they don't have a brain tumor or chronic subdural hematoma. Um, And as I mentioned, you want to make sure this isn't a major psychiatric problem or a delirium due to some metabolic issue that's acute. Again, the history is critical. If the memory problems have come on gradually over a year or two, that eliminates a lot of things. Uh, and again, we're trying to find things that we can either modify or actually treat. So you need to do a general neurologic exam, make sure that they don't have a hemiparesis or some obvious problem. And then cognitive screening is commonly done. Unfortunately, it's a little time consuming. Um, I would draw your attention to this test called the mini cog, because this is a really good, rapid way to screen older people for cognitive problems. Um, you have them do the draw clock test, which I'll show you in a minute, and you have them try to remember 3 words after 5 minutes. And this test has a pretty high sensitivity. It's not that specific, but a pretty high sensitivity. So if you're pressed for time, or if you're just seeing an older person for a patient visit, consider doing this mini cog. It doesn't take very long. I'll show you the draw clock test, as I said, in a minute. There's also the mini mental status exam, but I would say the most common screening tool is the Montreal Cognitive Assessment, the MoCA. So here's the MoCA. It takes anywhere from 10 to 15 minutes. It's hard to do in a routine visit. You may have to have the patient reschedule. In our clinic, we taught a couple of the medical assistants how to do this test. They enjoyed learning how to do it and doing it, and they did it well. So if you have a clinic where you have an elderly population, you might see if you have a medical assistant who would be interested in learning to do this, because then they can do it and save you lots of time. But the Montreal Cognitive Assessment is really the most widespread used screening. So I would say if your mini cog is abnormal, then the next step would be to do this. Here's the draw clock test. You draw a circle, you say, and then you put the dot in the middle, and you say to the patient, fill in the numbers, and put the hands in so that it says 2:30 or whatever time you want. And you can see that even in MCI, the patient's ability to do this is impaired. And of course, in late Alzheimer's, they just can't do it at all. So the draw clock test is a very, very good screening tool, and I recommend it. So you've done your MoCA, the patient scores 22 or 21 out of 30. You really suspect they have dementia. You want to rule out any treatable or modifiable problems. So this is a list to think about. Most of these people should be imaged. MRI gives you more information. A CT is adequate because you're ruling out a large frontal mass like a meningioma. You're ruling out a chronic subdural hematoma. You're ruling out hydrocephalus. So a non-contrast CT is adequate. It's easier to get. Patients can tolerate it better. So that's something to consider. MRI gives you more information, particularly about vascular disease. And they can also look at the size of the temporal lobes, the size of the hippocampus. They can tell you if there's hippocampal atrophy, which is a very sensitive finding on MRI and indicating, most likely Alzheimer's disease. Blood work, thyroid tests, and a B12 test is standard. You should think about sleep apnea. Severe sleep apnea can cause cognitive decline for sure. Again, think about depression or anxiety as either complicating the problem, or if it's severe depression, certainly that might explain cognitive decline. Obviously, alcohol overuse. And then be sure to look at their med list. older people on benzos, opioids, and particularly anticholinergics, even Benadryl, the bladder medications like ditropan, tricyclic antidepressants, amitriptyline, neuroleptics, uh, dopaminergic drugs like metoclopramide, any other sedatives. Really focus on the med list because these drugs can make things worse for sure. So there's no dementia panel, but I would recommend a B12 and a TSH and a brain imaging study. As I said, neuropsych testing takes hours and hours. It's expensive. It's hard to get. I would say that in the typical older person with the typical presenting symptoms of Alzheimer's disease, you don't need formal neuropsychological testing to make the diagnosis. If you're dealing with a 50-year-old highly functioning person and they're having cognitive decline, you're probably going to need it, and your consultant will probably recommend it or order it. There is a test now, a PET scan, positron emission tomography scan, which in this case uses a glucose marker. This can differentiate Alzheimer's from frontotemporal dementia. This would be ordered in a subspecialty clinic, and just be aware that it's out there. A PET scan looking for this protein that we're going to talk about in a minute, amyloid. This is an amyloid PET scan. It's just been approved. It is the gold standard for detecting this protein in the brain, which is highly correlated with Alzheimer's disease. But routinely, this is not done. You don't need it to make the diagnosis. It will be needed in some cases when patients are being considered for therapy, as I will go into later. But you don't need to worry about ordering that. It's not necessary to make a diagnosis. Now, I'm also going to talk about blood tests for Alzheimer's disease. This is a very hot topic, and I'll go into this later. And so I would just say it depends on your history again. If you're dealing with an 80-year-old with a typical presenting history, and you do the other workup, I don't think you have to do a lot of fancy scans to make the diagnosis. But if you're dealing with a younger patient and you're going to want consultative help on this, of course, or there's a rapid progression, you have to tailor the workup. Occasionally, people should have an LP and some of these more sophisticated tests. So why do we diagnose this, and why do we want to know? Because occasionally, unfortunately, not that often, we find a treatable cause. But we do find modifiable things even in people with Alzheimer's. There are symptomatic treatments, which I will go into in a minute. They're not that great, but they may help some. And then I'm also going to talk about the new monoclonal antibody medications. But also importantly, the patients and their families need to know what they're dealing with, and they need to know the prognosis so they can plan. They might be interested in getting involved in clinical trials. They might be interested in getting in support groups. So I think making a diagnosis is important. What can we do to reduce the risk of Alzheimer's disease at this point? So again, some people, a substantial number of people, have both vascular changes in their brain and Alzheimer's changes in their brain. And it's clearly been shown that managing cardiovascular risk factors reduces the risk of developing Alzheimer's. So in the patient who's cognitively normal, doing what you all do all the time, which is aggressively manage vascular risk factors, can also help stave off dementia. There's also good evidence that regular exercise, a Mediterranean diet, is important, and cognitive activities in older folks that involve social interaction can reduce the risk. So not doing puzzles on the computer, but going to a book group, being involved in playing bridge, just doing cognitive activities in a social setting has been shown to be helpful. So that should be encouraged. Treatment. Well, we've had these drugs now for many years, the cholinesterase inhibitors. There isn't much difference between the ones out there. Some are oral, some are control release patch. There have been many, many studies that do document a modest improvement in behavior, in mood. They do not help memory, unfortunately. Don't The patients and families should be told this isn't going to solve the memory trouble. Most commonly used one is donepezil, Aricept, but there are other forms available. I would just consider donepezil 5 milligrams at bedtime. See the patient tolerates it for a month and go to 10 milligrams. Most common side effects are GI. Memantine shows some very modest benefits in the middle to the end stages of Alzheimer's. They probably cause the patients to be a little calmer, a little more cooperative, which is not trivial if you're the caregiver. So consider this later on in the course. As I said, review the other medications. I won't belabor that. Now, anxiety and depression, that can be treated. I would recommend you use newer medications. For instance, citalopram at low dose, 10 milligrams, can really help with anxiety. Um, and also, if the patient has severe sleep apnea, that should be treated, of course. Now, what do you do when the patient's agitated and the caregivers are pulling their hair out and they don't know if they can keep going? There's only one FDA-approved antipsychotic for treating Alzheimer's disease, and that's this medication listed here, uh, brexpiprazole. Now, it's extremely expensive. And commonly people are using other medications. Quetiapine, Seroquel is a good one. It's off-label for this indication. These drugs all carry a black box warning about increased risk of death. So you need to give informed consent to the family about this. But sometimes you don't have much choice. And using low-dose quetiapine, perhaps starting at 12.5 milligrams or 25 milligrams at bedtime, is appropriate with the appropriate counseling. So we're going to shift gears here. We're going to talk about amyloid. And this has been the deposition of this protein, amyloid, has been the mainstream theory for what causes Alzheimer's disease for over 25 years. And it's very clear in the people who have Alzheimer's disease, they have this protein in their brain. It's widely deposited, and it shouldn't be. But also associated with this amyloid protein is another protein, which shows up as these structures called neurofibrillary tangles. And in these, you find tau protein. These are basically the skeletons of the neurons that have died. So amyloid and tau are the two proteins that are found and are pathognomonic pathologically of Alzheimer's disease. So there's the neurofibrillary tangle that has the tau protein in it, and it's basically a dead neuron. And there's the amyloid that's been deposited. So we can do these PET scans now. They can pick up amyloid deposition in the brain, very clearly. And you can see as the disease progresses from left to right, there's more red, there's more amyloid in the brain, and PET scans, amyloid PET scans, can be very useful in cases where diagnosis is unclear, but also we'll talk about the new treatments and how an amyloid PET scan uh, can is needed before you amyloid PET scan or a lumbar puncture is needed before you consider these new treatments. So what is this amyloid hypothesis? I'm afraid I have to go into this a little bit so that you have an understanding of what these new treatments are about. There is a normal protein, amyloid precursor protein. It's a transmembrane protein, and it does a lot of things that are normal functions of the brain, neuronal development, and other functions which are normal. And then normally, this a part of this protein, amyloid beta, is cleaved by enzymes, and it's degraded and removed, not deposited. It should not be deposited in the brain, it should be removed. So here's the amyloid precursor protein. It's transmembrane protein. This is normal to have this. We all have it. And then the enzymes cleave it. And one of the portions is called beta amyloid. But for some reason, it's unclear, maybe the result of aging, genetic conditions, other abnormalities, no one's quite sure. The amyloid beta, instead of being removed, is deposited. And it's thought that this plaque, this deposition, is toxic to neurons and leads to neuronal death, brain atrophy, and dementia, of course. That's the amyloid hypothesis. So here's the plaque. The amyloid, which should have been removed, the beta amyloid, is actually deposited in the brain itself. You can see it neuropathologically, as I showed you. So for years and years, people have tried to get rid of this amyloid. There's been vaccine trials, other medications, um, and they were never effective. The trials were negative. Um, And to this date, this amyloid hypothesis remains controversial. There are prominent people in the field who do not believe that amyloid is the primary uh, uh, pathologic problem in terms of creating Alzheimer's disease. It's interesting, I ran across this, that the current clinical trials, only about 25% involve anti-amyloid treatments, and 75% are directed towards other mechanisms, neuroinflammation, there's neuroprotective drugs being tried. So again, I don't think that amyloid is the final answer as far as what to do about Alzheimer's disease. So now there are monoclonal antibodies that use amyloid deposition. They target amyloid deposition, and the immune system removes the amyloid. The goal is to slow or arrest the progression of cell death and dementia. As I mentioned, multiple trials over the years have been negative, but in recent years, there's been 3 drugs that have gotten through the FDA. The first one, aducanumab, is not being used anymore. I won't go into the details, but lecanemab, and then most recently, the bottom one, donanemab, are being infused, are FDA approved, and they do very modestly slow the decline of the dementia. So I would say the number to keep in mind is about a third after 18 months, the rate of progression has been slowed by 1/3. So it's a modest effect, but it appears to be real. This is an older slide. Last year, this publication talked about the challenges of getting people into dementia clinics, getting them evaluated as to whether they should be infused. It was a slow process and bumpy. Also, insurance coverage has been somewhat bumpy. So now we have the second one, donanemab, which has some advantages and disadvantages. This is the most recent one. It was just approved last year, last July. And the good thing about this drug is that it can be stopped after a year if the PET scan shows a clearing of the amyloid. So this newest one has that advantage to it. So who is a candidate? Well, it turns out to be only a very small portion of people with early dementia or mild cognitive impairment are candidates. You can't be in the middle stages of dementia and have these treatments, and certainly not the end stage. So it's early on that people could be considered. There's multiple exclusion criteria, multiple medical comorbidities. Patients have to come in for infusions. They have to get multiple MRI scans. They have to have insurance coverage. And then this ApoE allele I mentioned, if there's a certain pattern that makes these drugs too risky in terms of one of the complications, which is bleeding in the brain. So it turns out there's only a minority of people that this could be even considered. So I guess the bottom line with this amyloid treatment is if you encounter a patient who has amnestic mild cognitive impairment, they come in with memory trouble, they're otherwise doing pretty well, they're in good health. I think they should know about this, and they could be informed that they'd have to go to a dementia clinic, a memory clinic, often in a university setting, but any large medical center probably has them these days, and they'd have to see a specialist. The wait time's probably going to be a long time, but it can be considered. It's certainly not a cure, but it might definitely slow the progression of patients. So the candidates would be someone with mild cognitive impairment or very early dementia. Now, biomarkers. There are spinal fluid biomarkers that have been around for a while looking at beta amyloid and tau protein. Of course, an LP is somewhat cumbersome. It isn't done routinely to make diagnosis, but it has been available. The most recent thing is now there will soon be available blood tests looking at beta amyloid and tau. So this was a study done in Sweden. They tested 1,200 people with memory impairment. They compared the results of their blood tests to amyloid PET scan, the gold standard, and cognitive testing. So these are people who are symptomatic, had mild cognitive impairment diagnosis, and then had the blood tests for beta amyloid and tau protein, and these blood tests were 91% accurate. So this is the future, I think, of confirmatory testing in Alzheimer's disease. Not yet FDA approved. There's some varying methodology, as there often are with new tests like this. So there's some things that have to be sorted out, and they're not covered by insurance. What should you do if someone comes in the clinic and says, well, my brother has Alzheimer's disease, I'm doing fine, but I want to know if I'm going to get Alzheimer's disease? don't order these tests, even if you can get them, because they can be very misleading. And someone could have a positive test, be 75 years old, be fine, and not develop Alzheimer's disease till they're 95. It leads you nowhere. It would just create anxiety. So at this time, I would recommend against any consideration of screening with these blood tests. Stay tuned, things may change. What might change? What might be the future? Well, if someone has suspected Alzheimer's disease, mild cognitive impairment, or early onset, early stage of Alzheimer's, we might be getting these blood tests to confirm the clinical diagnosis and to screen people for further testing, such as a PET scan. Someday, if there is treatment that would be indicated pre-clinically in high-risk patients, let's say people who have a strong family history, uh, there are trials going on now looking at whether getting rid of amyloid in their brains prevents dementia. So that might be the future. So stay tuned. This is a really rapidly evolving field. Okay, that's all I had to say. We have some time for questions if there are any.
All right, thank you, Dr. Mesher. We do have a few questions in our Q&A box. Let me pull that up here. First question is, what about checking for heavy metal toxicity with cognitive impairment? Do you do this, for example, mercury?
Not routinely. I think if there was some occupational exposure or some concern, you could do it. It's not recommended in the guidelines to routinely do that.
Okay, awesome. Next question says, what toxins do you check for? It was listed to rule out on one of your slides.
Well, I don't remember exactly what I was thinking in that slide. I mean, I think the toxins that I'd be most concerned about would be alcohol, illicit drugs, that sort of thing. I didn't mean to imply environmental toxins.
Okay, great. Next question. When do you order a non-contrast MRI instead of a CT with cognitive impairment?
Well, I think again, your MRI is going to give you more information. It will show the burden of vascular disease. So if you see lots of small infarcts, uh, that would indicate that there's at least the possibility of a mixed dementia. And then the other thing they can do is they can do what's called a volumetric uh, measurement of the temporal lobes. And they have normative values. And if the temporal lobe structures, particularly the hippocampus, are markedly atrophied, markedly shrunken, they will give you a number and say, this is abnormal, this is below normal. And that's in the right clinical setting, when you've done all your assessment, you've done your MOCA, and the history is consistent, that is really highly, highly suggestive the patient has Alzheimer's disease. So you get more information. Again, a non-con CT rules out the big structural abnormalities you're concerned about. So if the patient has good insurance, you can order an MRI and they can tolerate going in the MRI machine, that's fine. If none of the above is there, they're claustrophobic, they don't have insurance, a non-con CT, I think, is a really reasonable alternative.
Okay. Next question, what symptoms do the, I might say this wrong, what symptoms do the cholinesterase inhibitors help?
They, I think in a lot of patients, they have a little bit of a calming effect. I think that they also make some people less apathetic, more engaged. And they do very modestly, again, across many studies. I just reviewed a meta-analysis on this. They do very, very modestly slow the progression of the dementia. So I think there's very little reason not to offer it in people with mild cognitive impairment, and particularly early dementia. Um, there's more data in early dementia than in just MCI. Uh, they're generic, they're cheap, and they're generally well tolerated. So it's one of these kind of things. It might help a little with their mood, their engagement. It may slow down the disease very, very slightly.
Okay. Next question is, some say this beta amyloid is a protective mechanism due to insults to the brain. What are your thoughts?
Well, honestly, I was an amyloid theory skeptic until some of these trials came out in the last 3 years. It's hard to ignore that removing the follow-up PET scans in these trials after the treatment are dramatic. They normalize. The amyloid is gone. These drugs are really good at taking amyloid away. And the clinical benefit is very modest, but it seems real. So I've turned from an amyloid skeptic to thinking that there's some role in the pathogenesis that amyloid plays in causing the disease, but it's really not the final answer. So that's how I feel about it. I doubt the amyloid's neuroprotective because they removed it in these with these monoclonals, and people didn't deteriorate. They actually had some benefit. So I kind of doubt that.
Next question, we have quite a few questions. What ICD-10 codes would get ApoE genetic testing covered, and when would you order it?
I don't know the codes that would get it covered. I'm sorry. I've been on the sidelines here for long enough not to remember the codes. When to order it? Um, I don't think you should order it very often, if ever, in the primary care setting. Because again, if you are homozygote for ApoE4, you have an increased risk of Alzheimer's disease, but you may never get it. Now, if someone is being considered for an anti-amyloid treatment, it's very important to get the ApoE4 because those people have an increased risk of complications from the treatment, hemorrhage. So in that setting, it's absolutely mandatory to get it. In the workup setting, in primary care setting, I would rarely get it, if ever.
Okay. Next question, when would you order a NeuroQuant, and what is that test exactly?
I don't know what a neuroquant is. I'm sorry. If there's another name or what it is, I don't know. Maybe we could Google it and then I would know, but I don't know that by that name.
Okay, yeah, we'll move on. If you want to ask to unmute, Lena, I can bring you off mute also to speak directly. We'll move on to the next question. Do you find that patients with diabetes and other inflammatory conditions tend to develop Alzheimer's diagnosis? If yes, any thoughts on using colchicine, colchicine to lower it?
Colchicine?
Yes.
Yeah, I'm not aware of any data about colchicine in Alzheimer's. There was a lot of flurry of interest in using anti-inflammatories, and that didn't pan out as far as helping. Ibuprofen, naproxen, this was a number of years ago. That didn't pan out. So I don't think that's routinely recommended at all. Diabetes is a vascular risk factor. It's clear that people with vascular disease have a much higher risk of dementia and mixed Alzheimer's vascular dementia. So, of course, managing the diabetes is very important.
Next question, are there any anti-tau protein therapies?
Not yet, and I don't know if there will be. Tau is the dead neuron and not thought to be itself toxic. It's the endpoint of the neuronal death process. So I'm not aware of that. It's a useful biomarker in the spinal fluid and then probably in the blood. Elevated tau indicates neuronal death. It's a useful biomarker.
Okay. Next question, does removing amyloid reverse MoCA scores or just prevent decline in studies so far?
There's no reversal, there's no improvement. It just slows decline compared to control groups.
Okay. Oh, she said, so back to the neuroquant question. She said a neuroquant MRI is an MRI that measures volume of different brain structures paid for by insurance.
Well, I think again, I think generalized atrophy is non-specific on a scan, but the quantitative measurement of the temporal lobe structures, the hippocampus, is very well, it's correlated. And so if that's what that is correlated with memory impairment and dementia. So I think we're probably talking about the same thing there.
Okay. Question, can you comment on SSRI risk to dementia? I have had a few patients inquire about it.
I mean, causing dementia, I'm not aware of that being a clear cause or risk factor for dementia. And in fact, we use low-dose SSRIs to treat anxiety in Alzheimer's disease. So I'm not aware of that.
Okay. There was a comment saying check out Dale Bredesen if you haven't already. He's doing some amazing work on reversal. What is your take on anti-aging protocols out there? mTOR disruptors such as low dose. You guys are hitting me with these words today. Sirolimus in combination with metformin, oxytocin, methylene blue, not all at once. These are being touted as possible preventions.
Yeah, I understand. I have to say I haven't looked into this extensively. If you go to the meetings, listen to the podcasts, dementia experts, these are not standard approaches that I'm aware of.
Question about the recording. Yes, this is recorded, so if anybody wants to listen back on this, it'll be posted in about 2 weeks. And we do have somebody asking to come off mute, so let me go ahead and unmute you. Okay. You're unmuted if you wanna, whoever raised your hand, if you'd like to speak directly to Dr. Mesher. Unless you accidentally raised your hand. All right, maybe an accidental hand raise. Let's see if there's any other questions here in the chat. Let me check. I don't see any other questions. Anybody else have any further questions they want to throw in the chat quickly or ask to come on mute? Speak directly to Dr. Mesher. Any last minute questions? Okay, any thoughts on over-the-counter supplements?
Well, there sure are a lot of them out there. You see them all the time advertised, recommended by various people on the commercials. I don't think there's any hard evidence. And again, in the guidelines, none of that is recommended. So yeah, I mean, I think I don't feel like that's something you should strongly recommend to anybody. If they want to take them, they're probably innocuous.
Okay. Someone just asked, do you know what leading US centers or international centers are actively working on this research?
Oh gosh, I live in Seattle, and the University of Washington is very much involved in Alzheimer's research. I would say there are memory clinics, dementia experts in all major academic centers around the country. Um, in Arizona, I know there are at Mayo and at Barrow, and any place like that would have be involved in clinical trials and be on the cutting edge of infusing anti-amyloid treatments.
Dr. Batista asked to come off mute, so give me 1 second. Okay, you're unmuted, Dr. Batista.
Hi, yes. Can you hear me okay?
Yes, we can hear you.
Uh, yes, okay. Great, so I have bad reception. Maybe I'll move over here. I'm actually taking a course on environmental medicine, and we do discuss about environmental exposures and how they affect like health on every single level. So I was just curious why you think it's not considered something important for dementia and cognitive decline in general.
Well, I guess I'd be interested in what I must say I kind of I have some ignorance about these kinds of environmental exposures, so I will admit to that. What what type of environmental exposures are we concerned about, or what have you heard about?
Yeah, I mean, I'm definitely just starting the course, so I don't know like data exactly, but the heavy metals, we were just talking about mercury last night and how dental amalgams with mercury just give off mercury for the lifetime unless they're removed. And the vapor can go through the cribriform plates and affect the brain. But NAC can help with removal and that kind of thing. So heavy metals, and then also some research has been done with mold and mycotoxin exposures. Um, and that's what I got so far. I'm sure air pollution, which is like everywhere too, must be doing some kind of thing too. Um,
Well,
yeah.
yeah, I can tell you the dental amalgam issue was a big deal in MS a while ago, and multiple
Mm.
sclerosis. People were all having their dental amalgam removed. That never panned out as was showing any clear effect when people looked at it. Um, are there, I mean, who knows? There's so much about the cause of these neurodegenerative diseases that we don't know. Maybe there are environmental toxins. I don't mean to downplay it. I just don't think we know at this point.
Okay, yeah, got it. Yeah, definitely learning myself. Thank you so much.
Okay.
Great questions, everyone. Let me see if there's any other, looks like one more question came through. No, we're almost at time, so any last minute questions, please feel free to put them in the box. This question is, there was a concern of high aluminum exposure related to the development of Parkinson's disease. Have you heard of this association?
Yes, I have, and I think that's not. I don't think that's proven at all. Um, there have been other, concerns with Parkinson's exposure to pesticides, for instance. Um, there's a higher rate of Parkinson's in people who played contact sports. Um, again, what causes cell death in Parkinson's disease is as mysterious as it is in Alzheimer's disease. And this is, everyone's looking for the Holy Grail here, and it has not yet been found.
Awesome. Great questions, great presentation. I don't see any last minute questions coming through. Again, everyone, when you close out of today's webinar, your CME survey will be available to get your CME certificate. And this presentation will be, or is recorded and will be on our MAVEN portal within the next 2 weeks if you'd like to re-listen. we got a thank you, excellent presentation. So thank you again, Dr. Mesher, for your time and your knowledge. And thank you, El Rio, for hosting today's session. And we hope everyone has a great rest of their day. Take care.
Thank you.